Hi everybody, welcome. Thank you for joining this Connect and Learn session organised by Boost. My name's Amy Aitken and I work for the Boost team. So we're joined today by Dr. Colette Hawkins, who is going to speak to us about the cost of dying and what are the routes to rights specifically. So we're going to hear from Colette, going to deliver a presentation for us, and then we'll have some discussion and breakout sessions afterwards to kind of really think through what this means for us in the North East and North Cumbria and what are the next steps, what can we take forwards. If you could just go to the next slide, please, Colette, that would be great.
Sorry, yes.
Thank you. So these Connect and Learn sessions are a series all on different topics, and they are really designed to help share and spread improvement work across the system. You can come together and connect with like-minded colleagues around specific topics to generate ideas, and as I say, with a real focus on taking improvements forward in your own work, team or service. Next slide, please. Thank you. Just a couple of protocols to remember for today. Mute when not speaking, please, just when Colette's going through her presentation. You can use the chat for questions and contributions. We have got a little bit of time for Q&A after the presentation before we head to those breakout groups. Please listen and with respect and be present as well, and do share the learning from today. We are recording the session, so that'll be made available via the Boost website afterwards, so please do share with your colleagues and anybody who might not have been able to make it today. Okay, so I'll hand over to Colette and thank you.
Thank you very much, Amy, and thank you for the Boost team for the opportunity and all the support that goes along with that. So my name is Colette Hawkins. I'm a palliative medicine consultant by background, but with a particular interest these days on the way we develop our workforce and hidden issues around end of life. So I'm going to be talking about a project that I've run called Routes to Rights, what we've done, the findings that we've had, and the main outputs from those. And that'll be a sort of thumbnail sketch through those. But I want to couch that by starting with perceptions from me on the state of end-of-life care in the UK, because that sets the framework for this piece of work. And hopefully will stimulate some conversation about where things need to go. So the first thing to say is that you may already be aware, but the NHS has a definition of what end of life is, and it's taken to be somebody who is likely to die within the next 12 months, which is actually a lot longer than a lot of people think. A lot of people think end of life means, hours, days, maybe even minutes. But actually we're talking about the last 12 months. And the way to identify people who might fall into that group is the surprise question. Would I be surprised if this person died within the next 12 months? And if the answer to that question is no, I wouldn't be surprised, then that is a gateway to some really important actions which are hugely supportive and important for the person that we're talking about, because it offers conversations around where they're at so they can start to prepare, both practically and emotionally. It looks at holistic issues, not just a clinical illness and clinical treatment plan, aligning what can be offered clinically with what matters to that person, as well as looking at planning in advance. And it includes really practical things like putting the patient onto the GP palliative care register, which puts extra vigilance around that person's needs and care. So it's actually a really valuable thing to do, even though it sounds on the face of it like nobody would want that label on them. But there are a lot of benefits to that, and I'm going to explain a bit more about that. So in terms of the state of end-of-life care in the UK, we obviously have a rather interesting spectre over us, which is the Assisted Dying Bill. And given that I'm talking about legislation, it would be remiss of me not to mention that, but I'm not going to focus on that, because for me, what that's done is put the current state of end-of-life care into the spotlight and gives the opportunity to explain that there are routes to rights now. We don't need new legislation for people to have choice. And one of the really interesting things from market research type things around public support for the assisted dying proposal is that people view it as their route to dignity in dying and their route to choice. And it really should be neither of those for the majority of people. But it says something about how people experience end-of-life care, that people feel that's what's needed. Interestingly, with that market research, about 66% of the UK public have personal experience of witnessing what they felt was a poor death. So that we're not talking about something that's sort of tucked away and occasional. This is actually a prevalent problem across the UK. So death has become a medical event. There is default to crisis management, which means generally acute unplanned admissions as people are towards end of life, so in that last 12 months. And the underpinning reasons for that is that people are not being recognised, so the surprise question isn't being used. Even if the surprise question is used, conversations are relatively infrequent and often not sufficiently honest for people to really understand what's happening. And therefore, people are not able to enact any choice. And that's really critical. So there's clearly a human cost to that. And we know that people being whipped into hospital to manage an acute crisis, which nobody has pre-thought through, can be quite damaging for people. It takes them away from everything that's familiar to them, their loved ones, pets, the life around them, the community around them, and puts them into a sterile environment where they often feel a bit lost. So, and it's not just a human cost, there's an economic cost as well. And this report from Marie Curie, which was published earlier this year, the public expenditure in the last year of life, this infographic is pretty powerful, I think. This looks at NHS expenditure for people who turn out to be in the last 12 months of their lives. And the dark yellow on the right-hand side is the bit that I want to draw your attention to. And that takes 56% of, well, it took 56% of the NHS payment to people in the last year of life in 2022. So that's the year that this report relates to. And that amounts to just under £7 billion of NHS money was spent on acute unplanned hospital admissions for people who were in the last 12 months of their life. Now, my clinical practice was in hospital, so I'm the first one to say that for some people, that's absolutely critical. It's really important that they are removed from a situation which is just desperate at home. People are struggling. It's very stressful and very emotional. So I completely understand that, as not to say that sometimes this isn't necessary. But the point that I want to make is that for some people, this is not what they want and they've not been given the choice. So that's the bottom line for that bit. The other thing in terms of the state of end-of-life care that I just want to frame my research in is how exclusive it is. It is very inequitable, and some people miss out completely on anything to do with support and care towards end of life. We know who the groups are who are likely to fare less well or have poor experience towards end of life, and they're big groups of people, including people, for example, who have chronic long-term conditions. So we know this, and really those inequalities and exclusions need to be challenged because, again, people are missing out on their rights. So in amongst all of this, I think individual people feel very lost, very confused, disempowered and disadvantaged. And apologies if this is a crude analogy, but I actually feel a little bit like it's a bit like baggage reclaim at the airport. People are like the suitcases that go onto the conveyor belt of healthcare, and they just go round and round. And far too often, they're not being given the choice, is this actually what you want? So that's my problem. And to explore that, a group of us really wanted to go back to the roots. What are people's rights in all of this? What does the law have to say about the way we deliver end-of-life care? So the Roots to Rights work was set up around 2017, and in that time we've had a series of funded projects which have done these key things. We've built a stakeholder network across the UK, which covers a lot of bases in terms of relevant organisations. So that's across a lot of health providers going into services like drug and alcohol services, some of the more hidden groups, as well as community groups, charities, legal services, advice services, statutory organisations like Department of Work and Pensions and job centres. So lots of different organisations that we recognise are relevant to this group of people. And we asked this stakeholder group, what do you think of when you think about legal needs in people who may be in the last 12 months of their life? And we didn't really know at that point what we were going to get. So we didn't really want to ask a more closed question than that. We just think, well, where is the law in all of this? What do you think? And what's already out there in terms of material and services that is helping people to enact their rights? We had a lived experience group which was phenomenal in really getting us to understand what it's like living towards end of life when you're needing to look aside from the clinical stuff. What is life like? And what does it feel like in terms of getting the help that you need? And that helped us understand a bit more about what's actually needed to move this agenda forwards. I'm just going to touch on what we learned fairly briefly. So the stakeholder engagement essentially helped us to understand that the law fits into two key categories around end of life. One is choices in health and care decisions and people's rights around those and professional responsibilities to support those choices. The other, and this was a huge learning curve for me, is day-to-day life and rights and entitlements and protections to do with day-to-day life. And I'll tell you a bit more about those. So what do we learn about choices in health and care decision making? Well, what we learned is these things. People are unaware that they have a legal right to choice when it comes to their health and care decision making. And the reasons underpinning that is that they're not being recognised as potentially end of life, a lot of them. And either way, whether they're recognised or not, discussions are not happening. And that may be that conversations are occurring, but people don't understand what's being said. Professionals are not confident in being clear, and there's a lot of euphemisms being used or talking round things. And people are just ending up feeling very confused. And a good example of that is DNA CPR conversations, where I think there's confusion on the professional level about whose decision actually is this. And we had people describing that they were being asked, should we resuscitate your husband, your wife, your mother or not, and feeling a huge burden of responsibility of agreeing to what they thought was, shall we keep them alive or shall we let them die? And it was never their decision in the first place. So it was really interesting to experience from their point of view the problems of not having choices or having choices that weren't theirs to have. So it's been a bit of a muddle. So professional understanding of choice is where it's recognised that people have choices, actually not actioned very well. And that even things like shared decision making and the Mental Capacity Act, we're all aware of these things. And on paper, they look great, really important, understand the principles, but actually putting it into practice is another thing completely. And we've really understood that what people know professionally and what people then do in their clinical practice are not the same things. So what we're finding is this crisis management and the distress that goes alongside that. And underneath all of that, it really leaves me questioning, are we actually delivering legally compliant care? And I have to say that I think in many ways we're not. And for me, that's a really good starting point. We need to go back to what does the law require us to do and how do we support choice for the people we're looking after? So that's one aspect. The other is day-to-day life. And as I say, this was a massive education for me. I had no idea of this in my clinical practice. But social welfare law, so this is not law around complaints or negligence or anything like that. That's a different side of law. This is social welfare law, which says there are rights, entitlements and protections around a whole raft of daily life issues. So for example, you have a legal responsibility to buy a bus ticket. You know, the law says you need a ticket if you're going to ride on a bus, or you need your OAP pass. And you have the right to take an electrical item you've bought from the shop back if it doesn't work. So the law is all around us. We just don't really pay attention to it. But in the principle of social welfare issues, there are laws around the right to financial security, safe and suitable housing, rights around employment and education, guardianship, immigration. There are protections from discrimination, abuse and violence, and right to community care. And there's lots of other rights and entitlements as well. So this is quite an important area to really understand. And when we asked people what it was like looking at these issues, so this is the people with lived experience, it was absolutely obvious that social welfare legal problems are prevalent. And the big four were money, housing, jobs, and access and paying for social care. It was interesting because we didn't find anybody who wasn't affected in some shape or form. So it doesn't actually matter who you are, what your wealth level is, or what you know, these are likely to touch you in some shape or form. And that's often the carers of people who are ill as well. But it is important to say that if you're starting from a point of disadvantage, you are almost certainly going to have more social welfare problems, be more affected by them adversely, and have less likelihood of getting support. So although it's across the board, if you're starting from a point of disadvantage, things mount up and you're more likely to have trouble with these issues. And these are not small problems. These keep people awake at night. If people are struggling with debt and they're going through their clinical treatment, it may well be the debt that's keeping them up at night. People were feeling overwhelmed. They had, and the next bullet asking for help. The mantra that kept coming out is, we don't know what we don't know. We don't know what we're supposed to be doing. We don't understand these issues. We don't know what we're entitled to. We don't know how to access it. We don't know who we should be going to. So people were going back to the picture of the person in the fog. That's very much how people were describing themselves. But on the other side, there's lots out there. I was the one who went through mapping what's already out there, and it was unbelievable. There's loads of stuff, and it's really good. But trying to navigate online material to get information about something like CHC funding decisions, there is so much out there, it is overwhelming. So it's just a whole jumble of stuff. The other thing I've got there is critical notices, because we know, and it's not just this work, there's a whole body of evidence that shows that social welfare problems wrap up in ill health. And because people don't know where to go with their difficulty with debt or something like that, they will typically wrap up in a health problem and therefore present to the NHS. So you'll get a better sense of that as I go through. That means that NHS professionals are what's called critical noticers, because if an NHS provider doesn't notice that the person that they're seeing with another bout of COPD, a chest exacerbation, is going back to a cold, damp house, it doesn't matter how good their nebulizers are and how carefully they've looked at the chest x-ray, the cycle will just keep continuing. So NHS providers need to take note and take action. I'm going to pause because I just want to share a story. One of the outputs is professional learning, and I use stories to share and stimulate conversation around areas for learning. And I just want to share this story. This is an actor, Peter, but he's sharing Dave's story, which was something we took in during COVID, so we couldn't film the way we'd normally do it. So Peter is using Dave's words to share Dave's experience, and you get a better sense of what this is about.
My name's Dave. and I live in an old pit village near Middlesbrough. These last 6 months have been a nightmare for me. I was feeling ill, just not myself, but it came on slowly, so I just ignored it at first. Then I started with headaches. My vision wasn't right, and I couldn't eat properly. I went to see my GP, but he couldn't find what was wrong, so he sent us to see a specialist at the hospital. All this time I was struggling with my job. I was working as a machinist. I've been with the company a good few years. I needed a bit of time off sick. I'd never asked for it before. And my employer kept pushing me to work, but when I told him I wasn't well and I couldn't do the job because of my eyes, well, he sacked us. I told him, you cannot do that. But he said, we can do what we want. I was absolutely devastated. I didn't know how to get by. I had no money coming in. I couldn't keep up payments for my car, so that I'd got repossessed. My car really meant something to me. It was like my independence. I had all sorts of plans in my head. I was going to visit family and I was going to go to Scotland and the lakes, but I can't do any of that now. I'm relying on other people now to drive me to the hospital. I absolutely hate that. But it was my flat that was the real worry. It's just a small place. I live on my own. I just didn't have the money to pay the rent. I was hoping they'd give me more time. I was back and forth to the hospital, having scans and the like. They found the problem in the end, and it was a real shock. They told us I had cancer. Well, everything happened very quickly after that. I was straight into radiotherapy and told us they couldn't operate. All this was going on and I was getting letters from the landlord. I couldn't face them, so I didn't open them. I didn't know what to do. Every time I went out, I was worried that the locks would be changed and I wouldn't be able to get back in. Since my diagnosis, I've had help from Macmillan to sort my money. And that's really helped. Don't get me wrong, but there's just so much going on now. The radiotherapy makes me tired, but it's hard to sleep because my mind won't switch off. Things go round and round in my head. Like, what happens if I can't look after myself? Or manage my own affairs? I can't get my head round it. I'm trying to keep positive. But I don't know. I just don't know what I'm being positive for.
So I learned a lot from Dave's story. He was really devastated when his car was repossessed. And what was really interesting for me was the fact that he was risking not turning up to hospital appointments, partly because he didn't like to ask for a lift, but also because he didn't want to leave the flat. And from the hospital service point of view, he could have easily had DNA, 2 strikes, you're out. And when you realize what life is like for people, suddenly your perspective can change. So this slide just demonstrates essentially what Dave has said, that poor health creates social welfare legal needs. Let's see if this, yeah, there we go. So you start with a health problem. If that disrupts work, you can lose income, potentially at risk of non-payment of rent, and then potentially at risk of eviction and homelessness, and the cycle goes round. And obviously it doesn't have to be that dramatic. The health problems are absolutely the consequence of social welfare problems like debt, difficulty heating the home, unsuitable housing. But similarly, those problems also create or worsen health problems. So it's like this sort of hand and glove relationship between social welfare issues and ill health. I've titled this The Cost of Dying, and I mean that in its broadest sense, but actually there is a really important point about poverty. Marie Curie is into its 3rd year and it's just literally released its 2025 report, Dying in Poverty. They're worth a read because it just shines a light on a problem that may well be hidden from health services. a take home for me is that poverty is highest in people of working age who are dying, and there are multiple reasons for that, which you can probably guess, around childcare, loss of earnings from giving up jobs or having to go part-time, including carers. But the other thing that I hadn't appreciated was that they don't get access to a pension. So when you're pension age, the pension provides a bit of a cushion. If you're dying younger than pension age, you cannot get your pension, no matter how much you've put into it. And that's a campaign issue that Marie Curie are trying to change. It's absolute nonsense. So poverty is prevalent. And I've mentioned this wide system across multiple organisations, which from the person who's trying to navigate it looks like this. And things aren't joined up, and people don't know how to navigate. So this is where Roots to Rights has a couple of outputs that I just wanted to flag with you. One is the website at rootstorights.co.uk, and a couple of things to just mention to you from the website. One is the public information tab. Now, this is essentially trying to get people from that fog to understanding the basics to get to the first point of help. This isn't it in terms of this will sort out your problem with debt. This is what you need to understand about debt issues, and this is a really good source of support. Now, as I say, there's loads of sources of support, and I've just been a bit picky and saying these are really credible places to go. Start with these. There are lots, but start with these. And we've covered essentially the frequently raised issues that people have. Again, it's not exhaustive, but it's the common stuff. So that, please do encourage people to use that, show it to them, help them navigate to the right place if needs be. That would be really helpful. I ran a webinar for carers recently, and they lapped it up, and because they just feel we need some information, otherwise we're lost. The other tab that I just want to draw your attention to is the chatbot called Access Ava. Now, this has been created by a different charity called Access Social Care, which is developed and run by social welfare lawyers who are aware that there are huge issues in social care provision for people in vulnerable situations. Now, the chatbot is brilliant, but is legally written and legally configured. So I've played around with it, and I have to say I found it quite hard, but it's certainly better than nothing. And so people who have more complex issues, like I've been told I can't get CHC, but I don't think that's right, it can help them work through their own individual challenges. But just to flag that it might ideally have somebody just helping them work through that. So it's just that you're aware that's there. The other output that we've got is a programme of interprofessional learning through stories like Dave's. And the way I do those is we show a story, we have an open question like, why do you think Dave struggled to get help? What stands out for you about the daily life issues that Dave experienced, and why might those have happened? So really broad questions, not because we know Dave's situation, but it just triggers thoughts about our experience, our clinical encounters, what we've learned along the way, and we start pooling that. And if you do that across multiple agencies together in the room together, the learning is fantastic. And we've got 4 modules. One is around inequalities and exclusions and challenging those. One is an introduction to social welfare legal problems. The third is responding to those social welfare problems together, collaboratively. What does that look like? And the other one is health and care decision making and making that lawful. The downside to this is that we don't have funding for it. So at the moment, we are doing it on a charged for basis. So that is my run through. I'm hoping that that stimulated some thoughts, some questions, some ideas that you have yourself. So I will hand back over to Amy.
Thank you so much, Colette. Really thought-provoking and powerful presentation. So yeah, certainly a lot to think about. So I'd like to open the session up now to anybody who'd like to pop the hand up if you've got any specific questions for Colette. Conscious, Alice, you couldn't turn your mic on, so feel free to pop something in the chat if you'd like to. So yeah, any questions? Nothing as yet.
Stunned into silence, sorry.
Yeah, absolutely.
One of the things that I've learned, oh, sorry. Oh, thank you,
I was going to say it's yeah, fantastic holistic look, I think, at individuals, isn't it? Absolutely, which we know is so important.
Well, I would say that I'm hoping that there's people here who come at this from different angles. Well, you will, whatever your role is, you'll have a different perspective on it. I have found the different perspectives that I've been hearing along the way really valuable. And that's one of the reasons why we get people in a room together, because there are no real right or wrong answers in this. And it's about sharing what we know and our expertise and our experience to understand this better and to try and make the experience better for people.
Absolutely. Oh, we've got something here from Ella, thank you. What work is Colette / the project doing with local authorities and social care teams?
That's a good question, thank you. We have been engaged with various councils. So the councils that have been most involved have been Gateshead and Middlesbrough. But I have links in with Sunderland and Newcastle as well. And that's through social services, essentially, and social welfare teams, some of the benefits type services that go on in councils. Social care providers were more visible right at the beginning of the project, where we had some care home managers involved. I have to say I found them quite difficult to engage, and some domiciliary care providers as well, actually, sorry. But they have been really difficult to carry along with the project. But they're critical because they are, well, as far as the home care providers are concerned, they are eyes on people who are outside a health setting. So they will be seeing things, picking things up, hearing things that are really important for the holistic picture. And of course, care homes are really valuable in terms of enacting choice. And there's been quite a lot of concern about provision of choice around healthcare decision making from care homes. And I think there are a number of barriers to that, including things like staff turnover, confidence of staff, level of staff, sort of what's it called, sort of how experienced staff members are, particularly out of hours. So, for example, if somebody has gone to as far as writing something about advanced planning and how to manage crises, depending on who's present at the time, can influence whether that is actually carried out or not. And we've had quite a lot of examples of advanced plans being overruled in care home settings. So there is a big piece of work that needs attention there. If anybody has links into care providers, then please do let me know, because I could do with refreshing that, actually.
Great, thank you. Any other questions? There's nobody with the hand up at the moment. So what we'll do in that case then is we will move into our breakout session. If you wouldn't mind moving the slide for me, please.
Oh, sorry.
That'd be great. Thank you. Yeah, so there's a couple of questions that we like you to consider in your discussions, and you'll have about 10 minutes to do that. So now's your opportunity to take a quick screenshot or a picture on your phone if you'd like to take these questions. And we can see if we can pop them into the chat for you when you arrive there as well. So the questions are: what stood out for you about legal rights in healthcare, and what opportunities can you see for improvement in the North East and North Cumbria? So, interested to hear what you've been talking about. Is there anybody who would be happy to kind of share and summarise conversations, provide your own kind of personal thoughts and reflections?
It's not how much you change, it's
Do
how
feel free to pop your hand up. Oh,
you
I'll
change.
somebody's not on mute by the looks of it. Just bear with me a second. Jennifer, you've got your hand up.
Yeah, I think in our group we were talking about, do you know how difficult it is for a patient and their family when they're in this chaos of palliative care, and how, I suppose for our team, staffing is an issue, because we would like to walk alongside people as they go through that journey, but we have 2 people for the whole of the area and we have 700 patients. So one would be a staffing issue in terms of improving things, but 2 would be training us, because we don't know all these legal things. We don't have all this information. And, you know, with the best will in the world, you can have a session like this, but it will change and things will change, and there's not all of the team here. So, you know, it's just about educating a lot of the professionals to make sure that they know what they can do and what the rights are of people when they're in that situation. Because even if you know them, do you know, if you're a nurse and your child falls over, you go, oh my God. Well, most of the nurses I know go, you're fine. But you do, you go, oh my God, don't you? And then if somebody else's child falls over, you're straight in there, you know what to do. Because once your heart's involved, your head kind of gets a bit mushed up, and you don't always have that kind of foresight and thinking and strength sometimes to get what you're entitled to and chase that up. So I think if the professionals are involved are better educated about what exactly are the rights and what we can do and what we can support with, and some information be given in writing, because it's not ideal, but we don't have the staff certainly in our team to walk alongside. But if we could give something, if we knew what was correct, and we could give them something in writing or a point of contact for the duties team, that might help. But yeah, I think what stood out for us was, you know, how much it's not just families and people who don't know, it's us as professionals as well. And that's quite scary.
Yeah.
I think that's all really important points that you've made there. Thank you very much for that feedback. And you're absolutely right. And I speak for myself. As I said before, the social welfare daily life stuff was a complete closed book to me. So a couple of things I would say about that. I think in terms of you providing legally compliant care and enabling the rights of the people you're looking after in your role, which I'm presuming is healthcare. You're saying you're a nurse? Yeah.
No, I'm not. I'm a social worker. But
oh, sorry, I beg your pardon. Sorry.
Most of the people in my team are nurses, so
right,
we work in continuing healthcare. So we do lots of things like fast tracks and things like that.
So I think in terms of what professionals know, I totally agree with you. You can't know everything, and there's absolutely no need for everybody to have really very much knowledge at all in anything outside your day job, because we're talking about areas of knowledge, and as you say, it changes regularly. So things like benefits, you have to really be a benefits advisor to understand benefits and how things change over time. So what I would say to that is, please feel free to use the Roots to Rights yourselves as professionals, because there's information on there that it doesn't matter who you are. I'm hoping it will help with some of this really foundational stuff. And it will also help if you pick somebody up, for example, who may say, look, I can't feed the family, and I'm choosing between that and heating the house. For me in my clinical role, I would just thought, no, I'm not having that conversation because I don't know anything about that and I wouldn't know what to do. On the website, there is a piece on that, and you would be able to say, okay, I think that this is a good place for you to take that concern and start unraveling that with them. So somebody like the Money and Pension Service, for example, So we've got some ideas on the website of where you can encourage people to go to. So you don't even need to know what's out there. But that said, I get what you're saying about pressure on teams because of capacity, and that's a massive issue. That's why I think we need to be working more connected, because if you had closer links with other teams that were supporting the same group of people that you're looking after, that might just make it easier, both for you and for the people that you're looking after. Building those links at locality level so that things are a little bit more system wide rather than just siloed is actually more efficient for the teams. So again, that goes back to the interprofessional learning and getting people together. I agree with you. I think a lot of this is about thrashing out some of the problems that people are seeing in practice and not saying, here's a load of facts for you, off you go and do it, because we all know that how difficult that is. And there are lots of barriers in the way to that. But if we get into a room together and say, okay, these are challenges that our client group or our patient group are struggling with, how are we collectively going to be able to respond to these such that we can meet the needs better than we are now? It won't be brilliant, but it will be better than they are now. So it's essentially a system. It's more than problem solving. It's learning together so that you can co-create solutions for your locality and work out the relationships with other teams that will help the patients that you're looking after. It's a bit of a long-winded answer. I don't know whether does that sort of come back to you with some ideas?
I could see Jennifer nodding there, so thank
Well,
you.
you can tell me if I'm naive, because I am a bit
No,
naive, but
no, I think that the signposting idea, because we're not all things to all people, but sometimes we don't know where to refer people onto or suggest to people. So I think, that would be helpful because, we do get people, take your example with benefits. We're not benefits trained. We're not allowed to give benefits advice because in the past people have given very wrong benefits advice and caused a lot of trouble. So we're told categorically, don't give it, you're not allowed. But if we know, I know you can say to people, well, contact welfare rights, their waiting list is out the door. But if you've got some good ideas of where to signpost people, you can't fix all the systems, but if you're sending people to the right place or giving them the right pointers, that's as much as you can do. But we don't even have them sometimes, so this is really helpful.
yeah, I think you're absolutely right. And it was quite a shock to me to realize how much is out there already that I didn't know about in my clinical practice. So my patients won't have been accessing those support services. Charities and community groups are fabulous, providing that bridge between a person who might be struggling in their living room and feeling in the fog and specialist advice and support. And quite a lot of charities give that specialist advice and support in-house anyway. So they're fantastic. But yeah, have a look at the Roots to Rights website. We nothing is sort of set in stone and unchangeable. So if people look at it and say, oh, that doesn't read very well, or you're missing something, feel free to drop me a line. There's a contact us tab. Very happy to adjust things as needed, but hopefully that'll give you some stuff to work with for exactly the sorts of problems that you're talking about.
Thank you.
Fantastic. Thanks so much, both. Okay, conscious of time, we're on to our last 5 minutes, and I did really want to move this on to have a think about, so what are our next steps in the North East and North Cumbria? And that was a really nice segue, I think, that discussion into this. So what is it we take forward and do next? Again, feel free to pop your hand up with any thoughts and reflections. Too much to think about. Deborah, you've got your hand up.
Yeah. So in our group, we talked about kind of a lack of guidance for when somebody is like end of life, and if we had I don't know, like a guidance sheet to think of, or so carers, family, and the person themselves can think about. So, when you say you don't know what you don't know, is there something like a prompt sheet where you can say, have you considered this? This is where to look. for the actual person and the family themselves, rather than reliance on the nursing team or the person that's wrapped around them. And I think sometimes it's never just one person. You ping pong between a lot of different services and people, and trying to understand who's give advice and support and who hasn't. So just a bit of that information to educate the patient or the person and the family would be, and carer would be really, really helpful. And we also thought about the navigator. So yeah, you have your social prescribed link workers within general practice, but actually do we have an end of life navigator? So you've got one point of contact where they could help you navigate everything that you're going to need. And that includes external as well as health. Just some ideas.
Those are really good points. Amy and I were just discussing the need to provide information direct to the public as well, because as you say, the professionals ultimately become a bit of a barrier. Potentially they may or may not have information, they may or may not have the time to give it. So yes, direct to the public is really important. I've been doing some sessions direct to the public, but which have been great. I've really enjoyed them, and I think they've got a lot out of it. But actually, the idea of having something written, I have to say I hadn't thought of that. So that's a really interesting one. Thank you. If anybody knows of routes to doing that sort of thing, then I'm absolutely open to that. The care navigator type thing is yeah. We tried to develop a project which was exactly that, and we hit the horrendous time of funding being pulled on everything, so we haven't been able to get that off the ground. But interestingly, our lived experience group was saying we should be using their experience. So that's another question, is whether all of the people who've lived it have something to contribute here. Well, they would love to, I think, is the bottom line. So some really interesting points. We haven't finished, but with the funding constraints at the moment, it is tough. So, but I'm always looking for opportunities to talk and discuss this further and collaborate. So feel free to reach out if there's more to talk about.
Great, thank you so much, Colette. And yeah, really interesting points. Ruth, would you like to come in? We've got 1 minute left.
Yeah, no, I was only thinking, hi Colette, and I'm sorry I joined late. I was thinking in terms of sharing information to the public, and I realise not everyone is IT enabled, but actually if we could develop simple information that you could link via a QR code, putting that up in lots of care homes and around the place, it might be a way of facilitating. It's not going to answer to everybody, but it's a way of a lot of people and families may be able to access more easily. I don't know. It's just thinking about how you get that. As I say, I know you need multiple sources, but perhaps using something simple that, you know, a lot of people do have smartphones. I appreciate there is a digital equity issue, but might be a way.
I would love to do something like that. I am totally not a tech person. So if anybody knows people who would be interested in looking at that with me, that I would love to talk about that. Because direct to public, empowering people, allowing them to feel heard is critical. Thank you for that suggestion, Ruth.
Yeah, great stuff. Yeah, that multimedia approach, kind of old school, sometimes works best. And certainly people got a lot more used to QR codes during COVID, where they were everywhere. So yeah, really good suggestion. Well, thanks everyone. A couple of people have had to dash off already to go to meetings, but yeah, conscious we are at 1 minute past. And thank you again, Colette, for that fantastic presentation.
Oh, thank you very much for the opportunity. Thank you.
That's great. Thank you, and hope to see you all again soon.
Thank you.
Thank you.
Bye.
Thanks very much. Bye.